How many of us routinely check blood pressure at each clinical visit of our patient? Think about it. Just ponder over it. How many of us screen asymptomatic patients for hypertension? How many of us are focused on evaluating the target organ damage once you see a patient with hypertension? How many of us look for the core thieves like diabetes mellitus, lipids, metabolic syndrome, CAD, and CKD? How many of us offer correct combination of treatment for hypertension? How many of us insist on continued therapy and follow? How many of us educate the patient not only on the drugs but importance of total lifestyle change? How many of us achieve the goal blood pressure in a given patient? By doing all of the above, we do know how much good we do. If negligent, Almighty is taking note and will sure punish us. This is to say that every patient you see, you must take the blood pressure. Once to detect hypertension, you must evaluate target organ damage. You must also look for asymptomatic people with possible hypertension. Comorbidities like diabetes, lipids, metabolic syndrome, CAD, CKD should not be ignored. Combination treatment is the rule. Total lifestyle change is a must. Goal blood pressure must be attained. This is a world of good to the patient. Okay. The syndrome and the co-thieves. Hypertension as an isolated entity, we stopped looking at it for the last 20 years already. Hypertension is not a disorder by itself. It comes along with diabetes mellitus, dyslipidemia, metabolic syndrome, chronic kidney disease, and coronary artery disease also. The central theme today is hypertension as an isolated disease is fundamentally wrong. It is not just about lowering a particular number in the individual. You keep that idea separately. The clinical mandate is they are the pallbearers of the grave of coronary artery disease. Who are them? Diabetes, dyslipidemia, metabolic syndrome, coronary artery disease are the four pallbearers to carry the person to the grave of coronary artery disease. The core solution is total lifestyle change, and this acts as a fundamental primary and secondary prevention matrix. Now, JNC 8 era is over. Now we are in the 2017 ACC AHA shift. The modern mandate is earlier JN7 we were talking about systolic blood pressure of 140 and diastolic about 90 as the cutoff. And target blood pressure above 60 we were keeping it as 150 and 90. And target blood pressure for CKD and diabetes we were keeping less than 140/90. Today, irrespective of diabetes or no diabetes, irrespective of kidney disease or no kidney disease, irrespective of the age, there is a paradigm shift in the redefining the stages of hypertension. Stage 1 hypertension, anything more than 130/80. Anything more than 130/80 on 3 consecutive readings on the same time of the day in the same arm, right arm in the sitting position. RUL sitting, 3 consecutive days you have to see. Then if consistently it is more than 130/80, you can label the patient as hypertension and start treatment. There is a universal targeted goal which is 130/80. The rationale is aggressive downward shifts are required to actively prevent structural organ damage. This is redefining the hypertension, which is the vascular blueprint. Now, organ-specific targets for presentation. So suppose somebody has got, to preserve the GFR and halting the CKD, you can even better keep it as 120. Somebody already has kidney disease, microproteinuria, albumin creatinine ratio is raised according to the KDIGO clinical practice guidelines. Kidney diseases guideline is that 2021 they said target blood pressure you keep it as less than 120. Ultra strict blood pressure management is very important. preserve the GFR, and halt the progression of chronic kidney disease. Pancreas and vascular pathway. Now, today, pancreas is not separate from the general body. Pancreas is the hallmark of insulin resistance. The compound risk management here in 2024 ADA standard of care guidelines, 130 by 80 is the target, tightened from the previous iterations to align with the modern cardiovascular outcomes and recognizing the severe compound risk of hypertension and diabetes together. So, for diabetes or anybody else, 130, 80, renal disease is there preferably at 120 to keep the EGFR in manageable limits. Now, CHD, stroke, CKD, PAD were thought as separate diseases earlier. Now, they are all only one disease. CAD, CKD, CVD, PAD, they are manifesting in 4 different vascular beds. They are not different diseases. They are only the same. This is a paradigm shift in the understanding of that. Now, uncontrolled hypertension can lead to endothelial dysfunction, arterial stiffness, can damage the heart, left ventricular hypertrophy, and then LVH, congestive heart failure, coronary artery disease, and then in the brain, cerebrovascular accident, stroke, and encephalopathy in the brain. And in the kidneys, we have chronic renal failure and nephropathy. In the eyes, we have peripheral, heightened the peripheral arterial disease, retinopathy, peripheral vascular disease, and PVD. What is the take home here? Core takeaway is cerebrovascular disease, renovascular disease, peripheral arterial disease, and retinovascular disease, and cardiovascular disease are not different things. They all have a common ground called the uncontrolled hypertension. Decreasing the blood pressure is not the goal. Decreasing the number is not the goal. Decreasing the number through that halting and reducing and regressing TOD, target organ damage. What are the target organs? Brain, eyes, peripheral arteries, kidneys, and heart. And improve the quality adjusted life years, also called QALY, is the ultimate goal. Some patient is obsessed, it is 140, 160, 170. Don't really focus on the number. Focus on the target organs and see that the target organs are protected. Now, integrated approach is a paradigm shift in the management. Clustering of 2 or more risk factors was found to be associated with cardiovascular disease. Interheart study has showed that sum of smoking, dyslipidemia, arterial hypertension, diabetes mellitus was responsible for 90% of the risk of myocardial infarction. Individual risk factors, blood pressure was one earlier. Now today, total risk approach, blood pressure, dyslipidemia, diabetes. The ABC of diabetes. A1C, B blood pressure, C cholesterol. Now, the paradigm shift in the goals, blood pressure control, CAD, MI and AF, then LVH, heart failure, LV diastolic dysfunction, diabetes, new onset diabetes, microalbuminuria, CKD, prevention of stroke. These are all only a single loop. It's a question of you understanding this logic and trying to prevent. What is wisdom? It is wrong to consider hypertension as an isolated disease. The truth is hypertension, diabetes, dyslipidemia, obesity often coexist. They are the 4 pallbearers to the grave of coronary artery disease and cerebrovascular disease. For all of them, primary and secondary prevention by TLC is the answer. Afflicted with one must be screened for all other thieves. What does it mean? A patient who have detected hypertension, you must screen for diabetes, metabolic syndrome, dyslipidemia must be screened. This is wisdom. If you are wise, you will do it. If you are foolish, you continue to treat the number only. Arm blood pressure to blood vessel. 50 years back, blood pressure was measured in the arm and thought that that's it. Today it is not like that. Particularly as consultants, you must go to a systemic vascular disease approach. Cardiovascular disease, and then you have got the CV and endocrine disorders as underlying may be there. CV, endocrine and metabolic disease. Earlier it was called a disease of the blood vessel. Then come to the systemic disease. Then it became cardiovascular disease. Now cardiovascular and endocrine disease. Now cardiovascular, endocrine and metabolic disease. Blood pressure measurement, contralateral arm should always be done, and all arms, particularly if we detect a hypertension, you must look at the contralateral arm also, preferably all the four limbs. Weight, waist circumference, and BMI are a must. Peripheral pulses must be palpated. ABI, ankle brachial index, and carotid buoy must be heard. Thyroid examination for hypo and hyperfunction. Cardiovascular system examination for LVH and heart failure. Abdomen for any masses, bruit, aortic pulsations. Fundus examination for early retinopathy. Who wants a person who is with grade 4 retinopathy and blindness? I am not interested to pick up a fellow who is having grade 4 retinopathy with complete blindness. I want to identify early retinopathy and see that it doesn't progress into higher grades. Physical examination and hypertension is a must. These things. As we often say, hypertension is the cause of so many things. Hypertension stroke, hypertension cerebral hemorrhage, hypertension chronic disease, hypertension encephalopathy, retinopathy, peripheral vascular disease, aortic aneurysm, LVH, myocardial infarction, coronary artery disease, heart failure. All these are called the target organs. Never forget to look for target organ damage. A paradigm shift in the treatment approach. It is not just lowering the blood pressure. Today we must strive to alter all the modifiable risk factors, keep systolic blood pressure 130 by 80 and not 140 by 90 as was given in the earlier recommendations. Prevent or halt or reduce TOD, prevent or control diabetes mellitus because the combination is murderous. Hypertension plus diabetes is murderous combination. Prevent or control dyslipidemia because all are leading to endothelial dysfunction. Reduce the morbidity and mortality, improves the quality of life. The practicing points for using WHO and ISH scoring system. ISH scoring system and WHO system says already on antihypertensive treatment, CVD risk may be higher than indicated by the charts if the following are seen. Already on antihypertensive treatment, premature menopause, a woman in 35-40 gets menopause, you have to be very careful. It could be underlying endothelial dysfunction. Low HDL, raised TZ, approaching the next age category or systolic blood pressure category. Raised levels of hsCRP, fibrinogen, homocysteine, ApoB, LPA, impaired fasting glucose, IgT. Obesity, particularly central obesity, microalbuminuria increases the 5-year risk of diabetes by about 5%. Sedentary lifestyle, raised pulse rate. Somebody hypertension and tachycardia, you should be very careful. Yesterday, I had a patient who is a software engineer. He is around 50 years and his blood pressure is around 170 by 100. And when we looked at the home monitoring using the 24-hour ambulatory blood pressure monitor, the blood pressure variation is so much. And the resting heart rate is around 98, 100 like that. So when we evaluated the underlying cause for him is sleep apnea and obesity. Sleep apnea is known to cause hypertension, endothelial dysfunction and all the havoc. Now we started treating the sleep apnea. Today I asked him to buy the auto CPAP. Family history of premature coronary artery disease and history of stroke in the first degree relative and socioeconomic deprivation. All these have to be looked into. Why is there target organ damage in hypertension? Because it is a disease of the blood vessels. That means the blood vessels are everywhere. So any organ which has got blood vessel can get damaged. What are the organs damaged? Heart, brain, kidney, eye, peripheral blood vessels. What is the basis of TOD? Endothelial dysfunction, atherosclerosis, and arterial stiffness. What test do we need to assess TOD? List discussed already in the previous slide. Okay. So this is the normal heart cut transfer section. This is a hypertensive heart which has got a very thick left ventricular muscle. Normally this is less than 10 millimeters. LV measurement should be less than 10 millimeters. Now anybody who has got more than 10 millimeters thickness, this is 33 millimeters thickness, this particular muscle, it is a concentric LVH. Sometimes there will be concentric LVH, sometimes there will be regional eccentric LVH. The vascular blueprint, left ventricular hypertrophy. LVH is the single largest predictor of mortality in hypertension. LVH is the single largest predictor of mortality. What you have to do, everybody whom you see with hypertension, you must get a 2D echogram and then get the estimate of the LVH. Okay, the structural this is the structural risk that one poses. So as time and disease progression, the mortality risk. So the longer the hypertension, the greater the mortality risk. The ultimate predictor is LVH is the single most important predictor of CHD, heart failure, and death. The vicious cycle, hypertension, LVH, LV failure, mortality. Reversibility factor, can LVH be regressed? Yes, very much yes. It is not a permanent scarring. If caught early, modern and aggressive treatment to less than 130/80 combined with ACE inhibitors and ARBs and diuretics are proven to regress this LV mass. So very important for you to understand LVH and how to control the LVH. Now you know this is the ECG changes of LVH, left ventricular muscle thickened, L1 very tall R waves, L3 deep S waves, left mid criteria, that will be the left axis deviation, and there will be T inversions in the left sided leads L1, L3, and AVL, and V1 S plus V5 or V6R will be more than 35. Okay, now survival time, survival rate, hypertension and LVH versus normotension and LVH. You see, normotension, no left ventricular hypertrophy. That is the best survival. Hypertension with left ventricular hypertrophy, worst survival. Normotension with left ventricular hypertrophy, next worst survival. Hypertension, no LVH is next. So, even normotensis left ventricular hypertrophy adds to the mortality. Now, what is the single most important predictor of CHD, heart failure, and death? Needless to say, left ventricular hypertrophy. LV also calculated as LV mass index. You now find out from your books what is LV mass index and do it. Small little homework for you. What is the time course of hypertension to LVH to LVF and death? Chart is explained. It is progressively higher as time passes. So can LVH be regressed? Yes. ACs, ACIs, ARBs, diuretics are the best. Other drugs like calcium channel blockers, alpha blockers, and these are not that effective. Will drugs help to regress TOD? Yes, all drugs reduce TOD, target organ damage, LVF, and CVA the most. How important is microalbuminuria? Most important prognostic indicator in a patient of hypertension or diabetes is microalbuminuria. How many of you are really ordering microalbuminuria and albumin creatinine ratio? I am sorry to say, what we read and tell you and teach you in the theory in classes is never followed. Now you see, LVH is the single most important predictor. D diuretics, and then AS inhibitors, B beta blockers, C calcium channel blockers. All of them reduce, particularly diuretics, ACE inhibitors. Combined, use a ACE inhibitor plus diuretic, drastic reduction in the concentric LPH. Anybody I see with hypertension, do an echo and find out there is concentric LPH. Immediately put them an ACE inhibitor and, if necessary, a diuretic. Now, will treatment help? Yeah, there is a 50% reduction in CHF, there is a 40% reduction in CVA, there is a 35% reduction in LVH, there is a 22% reduction in CVD, and there is a 18% reduction in the CHD. All these are, the damages of the target organs, all can be treated once you reduce the LVH. Resting and post-exercise systolic blood pressure in the ankle and arm must be compared. Normal ABI is more than 1, ankle blood pressure more than the arm blood pressure. Less than 1 ABI, less than 0.9, ABI less than 1, less than 0.9, 95% sensitivity for angiographic peripheral vascular disease. If the ABI is 0.5 to 0.84, correlates with the claudication. Less than 0.5 indicates critical limb ischemia, advanced limb ischemia. Don't forget to do the ankle brachial index if you have a patient of hypertension. Now, retinopathy, diabetes mellitus with microalbuminuria, a combination can give a retinopathy, nephropathy, non-fatal cardiovascular disease, peripheral and autoimmune neuropathy, all-cause mortality, and LBH. So you see, so many things are important for you to measure, and unless these are understood, the relative importance of MAU, microalbuminuria, 10 times odds ratio is more. Smoking 6.5, hypertension 3.2, cholesterol 2.3. Always we are worried about cholesterol. And most important, cholesterol is important, blood pressure is important, smoking must be stopped, and microalbuminuria must be measured and controlled. How do I control microalbuminuria? By prescribing ACI or ARB. Normal ABI more than 1. 0.9, I have already shown this slide. Okay. Now, there's another thing called the dippers and non-dippers. I told you about that patient with hypertension. I did also the 24-hour BP monitoring, I said. During that, this tipping phenomena is absent for him. This is the earliest indication of endothelial dysfunction, atherosclerosis. Normally, we see at least a 10% drop in the blood pressure in the early morning time or midnight, both systolic and diastolic. Okay, in patients who are non-dippers, this dipping will be absent. The same thing holds good for the diastolic blood pressure also. So you must always look for this dipping phenomena. I am one physician who regularly asks for ambulatory blood pressure monitoring and microalbuminuria, target organ damage, and then see whether these factors are there. Now, 24 ambulatory blood pressure monitoring, it also brings out the masked hypertension. See here, this fellow is supposed to dip here during the night, but the dipping should be more than 10 millimeters. If the dipping is less than 10 millimeters, they're considered as non-dippers. Advancing age, high baseline blood pressure, obesity and overweight, excessive dietary salt intake and alcoholism, chronic kidney disease, diabetes mellitus type 2, LV hypertrophy, black race, and female gender are clinical markers of a poor hypertension. A patient comes, don't just say you have blood pressure and then give him some drug and go away. Age, baseline blood pressure, obesity, overweight, dietary salt intake, alcoholism, CKD, diabetes, LVH, race, and female gender. You see, woman with hypertension is at a greater risk of damage than a man comparatively. So these are the clinical markers of poor hypertension. Narcotic analgesics, NSAIDs, aspirin, selective COX-2 inhibitors, sympathomimetic agents, diet pills, cocaine, ephedrine, stimulants like methylphenidate and amphetamine, alcohol, binge drinking, oral contraceptives, steroids, anabolics, cyclosporins, erythropoietin, lycorrhizine, herbal compounds, ephedra, etc. So whenever you see a patient of hypertension, all the medications must also be listed. Okay. Another important thing is watch for secondary hypertension. 95% of hypertension is essential hypertension or primary hypertension. No cause can be found. 5% of the patients, they have secondary hypertension, which is treatable hypertension. Once you treat the secondary cause, it is not a lifetime management. Young hypertensive, first time hypertensive after 60, well controlled hypertensive, now out of control. Three things you must keep. This is called secondary hypertension. Whenever you say young hypertension, or for the first time I am detecting blood pressure after 60, or it is very well controlled hypertension. Now hypertension control is not there, which will tell you there is a secondary hypertension. In a compliant patient on lifestyle change, what is resistant hypertension? I have a lecture on this separately. After 2 or 3 weeks, we will have a lecture on resistant hypertension. BP are not on target. 3 drugs are used, one of which is a diuretic. Then you call him as a resistant hypertension. At the optimal dosage, drugs are used. We'll have a separate class. Nomenclature of hypertension. Hypertension, resistant hypertension, secondary hypertension. Among hypertension, 100 hypertensives, 95% are here, 5% are secondary. Out of this 95, some 60 are here, which is not resistant, 30 are in the resistant group. Now, strong associates of resistant hypertension, type 2 diabetes, HbA1c more than 9, creatinine more than 1.5, BMI more than 30, obstructive sleep apnea, AHI more than 20. That patient whom we did the sleep apnea test, he had a AHI 46. What is AHI? Apnea Hypopnea Index. This is a summary index that will be given in the sleep test. It should be less than 10, preferably 5, 6, 7, something like that for all of us. So AHI more than 20 is obstructive sleep apnea of a severe degree, asking you to immediately start on auto CPAP. Okay. Systolic, difficult to control. Diastolic blood pressure might rise in the old age. Problems in hypertension. Now, major risk factors, target and organ damages. Morbidities, risk factors, target organ damage, hypertension, smoking, obesity, inactivity, dyslipidemia, diabetes, microalbuminuria, age, and more than 65 for women, more than 55 for men, family history, CVD, target organ damage, heart, angina, prior MI, prior coronary vascularization, heart failure, brain, stroke, TIA, chronic kidney disease, peripheral arterial disease, retinopathy. So some of them are components of metabolic syndrome also. The correct approach to treatment, are all patients screened for hypertension. Whomever I come in contact with the OPD, I must take the blood pressure. This is called opportunity screening. Are all hypertensives correctly identified? Are they evaluated for comorbidities and TODs? Must understand what is TOD and what is comorbidity. Target organ damage is in the brain, blood vessels, peripheral arteries, retina, and kidney and TOD. Comorbidities are diabetes, dyslipidemia, obesity, metabolic syndrome, smoking, all those things. Are they assessed for CH risk factors? Are the correct drug combinations prescribed? What is the compliance? Is he taking the medications? And is there a regular follow-up? Is the goal BP of 130 by 80 is achieved? Are the therapies and complications? Are there any complications related to the drugs? Hypertension in most patients is asymptomatic. What is the commonest symptom of hypertension? Asymptomatic. The answer must be asymptomatic. What is the commonest symptom of hypertension? Hypertension is an asymptomatic disease. Means what? I must screen everybody who are at risk to find out hypertension. They will not come with a symptom, usually. TOD and complications are often occult or hidden. Side effects of the drugs, cost and combinations are usually forgotten. Get a list of all the drugs patient is taking. Complexity of the regimens and timings, multiple medications and comorbidities, lack of understanding of the gravity of the disease, target organ damage, first belief, false belief that hypertension got cured. Some of my patients say, last time I saw you, I have given you some hypertension. Are you continuing hypertension medication? No, sir. I took the medicines for 10 days, what you gave. Now I am all right. It is cured. Most of the patients think because it is not visible, they think they got cured. I used it correctly, sir, for 10 days. After that, it got cured. So, did you check? No, I did not check. It has no symptoms now for me. So, it got cured. It's not like that. Social, economic, and personal factors. Non compliance, what are the causes? These are the causes. Now, lifestyle principles in hypertension, salt restriction, weight loss, physical activity, smoking cessation, alcohol abstinence, glycemia, and lipid control. The ABC. A is A1C, B is blood pressure, C is cholesterol. Now, beyond the office cough. So, we have the cough blood pressure here. Microalbuminuria must be measured. Ambulatory blood pressure you must concentrate. And dippers and non-dippers you have to see. And ankle break index you should not forget. Now, sympathetic overactivity, activation of the N type of calcium channel blockers. What will it do? Sympathetic overactivity, platelet activation, arterial thrombosis, cerebral infarction, myocardial infarction. Arterial thrombosis, excessive glutamate release via the N type of calcium channel, increased cardiac oxygen consumption, tachycardia, and increased oxidative stress, activation of RAS system, constriction of the postglomerular blood vessels, glomerular hypertension. This leads to chronic kidney disease, activation of renin-angiotensin, chronic heart failure, increased oxidative stress, tachycardia together, effort angina. So the end results are cerebral infarction, myocardial infarction, angina pectoris, heart failure, and then chronic renal failure. The more advanced the stage of hypertension, the greater the adrenergic activity. If it is a self-amplifying and it is a self-amplifying loop of destruction. If you find sympathetic overactivity, you must give them newer generation beta blocker. that is metoprolol 12.5 to 25 milligrams must always give. It is imperative to consider two drugs, not monotherapy at all. You don't prescribe monotherapy for tuberculosis, isn't it? Like that, here also there is no monotherapy. Always it must be a combination. One should be complementary to each other to achieve the adequate BP control. Two agents sometimes nullify each other's side effects. Fixed dose combinations will reduce the number of tablets. Once daily formulations are good for compliance. Chronotherapy, a new thing has come, what is called the chronotherapy. All hypertensive drugs except diuretics must be given in the night at bedtime. Take it. Or any hypertensive drug you prescribe, don't give in the morning because of partial hypotension and first dose hypotension. And the treatment is best useful in when you give in the night. This is called chronotherapy. Only exception is diuretics. The diuretics you have to give only in the night. Sustained release or long-acting formulations for 24-hour BP control. Use of triple drugs for therapy if goal blood pressure is not indicated. What is the paradigm now? No single drug. Most importantly, you must start on two drugs at least, not monotherapy. The drugs must be complementary to each other. Two agents sometimes nullify each other's side effect. Fixed dose combinations, number of tablets are reduced. Once daily formulations are better. Chronotherapy, any hypertensive drug must be given in the night. The only exception is diuretic, because if you give diuretics in the night, sleep will be disturbed. So if you want to give a diuretic in the evening, maybe 4 o'clock or 5 o'clock, you can dose it. The effect is over by before he sleeps. Otherwise, all drugs are prescribed in the night. Hypertension drugs. So sustained release or earlier formulation, long-acting formulations for 24-hour blood pressure control. Triple drug therapy goal is not achieved. Now, pathophysiological basis of hypertension. Increase in the vascular tone, sodium and water retention, abnormal sympathetic system activity, abnormal renin-angiotensin aldosterone activity, endothelial nitric oxide mismatch. Now, drug classes of hypertension. What are the various drugs I have and what are ACIs, angiotensin converting inhibitors, ARBs, and angiotensin AT2 receptor blockers, calcium channel blockers, and diuretics, and of course, beta blockers and alpha blockers. So basically, three, four groups, and then the beta and alpha blockers if necessary. Now you see, diuretic ACE. Whenever a blue arrow is there, that means the effect is additive. Whenever a black arrow is there, you have to be careful. Whenever you have a pink rose color arrow, data not available or controversial. Whenever you have an yellow or orange arrow, that means they are not additive. This you can always use. ACE inhibitors, beta blockers you can give, but there is no added benefit. Diuretics and ACE inhibitors, definite added benefit. Calcium channel blockers and ARBs, very good added benefit. Alpha blockers and beta blockers, added benefit. Alpha blocker and calcium channel blocker, you should not be combining them. So, like that, beta blocker and calcium channel blockers, you will not combine. So, generally, this is the guide which drug can be combined, which are the plausible drug combinations. This is the annotation here. This is the guide here, black, orange, pink, and then the blue arrows indicate those things. Now, there is a genetic link of RAS and CAD 5.3-fold. People who have high RAS activity and coronary artery disease, there is a link of 5.3-fold type. People with high RAS activity, they have high coronary artery disease. AC high circulatory effects, AC inhibitor circulatory effects are cardioprotective. Don't withhold the AC inhibitor unless there is a specific contraindication. What are the contraindications? Pregnancy is a contraindication. Bilateral renal artery stenosis is a contraindication. Relative contraindications, hyperkalemia, renal failure are relative contraindications for ACE. Otherwise, ACE must be used. Hemodynamic, neuroendocrine effects decrease the ED. These are the pleiotropic effects to reduce the IHD. These ACE inhibitors are anti-proliferative, anti-atherogenic, anti-thrombotic, and positive tissue effects. ACE inhibitors are vasoprotective. Why? They decrease the circulating AT2, angiotensin 2, and aldosterone, decrease the tissue AT2 in the endothelium and the kidney. They increase the vasodipressors and bradykinin system and produce vasodilatation. They decrease the SNS, sympathetic nervous system, and then anti-adrenergic inactivity. They're vagomimetic. They increase the antiarrhythmic, and then the normal heart rate is restored. Alteration in prostanoid mechanism, metabolism is also a feature of ACE inhibitors. That's why never stop withhold ACE inhibitors unless there is a contraindication. CCBs, calcium channel blockers, dihydropyrimidines, DHPs, non-dihydropyrimidines, phenylalkylamines, non-dihydropyrimidines, benzothiazepines, and non-selective CCBs. 4 types are there, out of which phenylalkylamines like verapamil and non-dihydropyrimidine, dihydropyrimidine. Short-acting formulations of nephrodipine are not recommended. Short-acting formulations of nephrodipine are associated with reflex CNS activation, flushing, tachycardia, worsening of the myocardial ischemia, and cerebral ischemia. Third generation dihydropyrimidine CCBs are gradual onset and long duration. Amlodipine is most commonly used third generation CCB. Newer drug, cilnidipine, is also very good. SNS, sympathetic nervous system role. Hypertension is a multifactorial and multifaceted disease. Sympathetic nervous activity is one of the major culprits for the onset of hypertension. Increase in the symptoms, increase in sympathetic activity is widespread and across many organs. So, what is the cause? Stress, sympathetic nerve activity, and type of calcium channels, leptin increase, obesity. That results in heart target organ, peripheral artery, kidney, skeletal muscle produces insulin resistance. On this arterial bed, they increase the cardiac output, vascular resistance is increased, sodium retention is increased, renin-angiotensin system is stimulated, so much so hypertension. So if you block the SNS, what are the drugs to use for SNS to be blocked? We use the beta blockers. What type of beta blockers? New generation beta blockers like carvedilol, metoprolol, nebivolol. These are the newer drugs. Not your atenolol or propranolol. Those are not the drugs to be used. Use the new generation beta blockers, preferably metoprolol or carvedilol or nebivolol or bisoprolol. These are the newer generation beta blockers to control the sympathetic nervous system activity. Now, you also have the SNS and complications of hypertension. Sympathetic hyperactivity triggers its complications of hypertension. SNS hyperactivity through the N-type calcium channels, platelet activation, increased cardiac oxygen consumption, tachycardia, oxidative stress, renin-angiotensin system. They produce arterial thrombosis, excessive glutamate, cerebral infarction, myocardial infarction. This produces hepatic angina, chronic heart failure, constriction of postglomerular vessels, and glomerular hypertension. Now, nice guidelines for the treatment of management of hypertension, younger than 55, older than 55. So step 1 is A. A is ACE inhibitors, and if it is less than 55, just 1A. If it is more than 55, C or D. Then step 2 is to the A, you add C or D. A plus C or A plus D. C is calcium channel blockers, D is diuretic. And step 3, not controlled with 2 drugs. You take angiotensin inhibitors, ACI and ARB, calcium channel blockers, and diuretic. So now, step 1, this was the 2006. Now, today, 2011 guidelines are NICE guidelines, National Institute of Clinical Excellence, NICE guidelines, age under 55, over 55. Step 1, A or C. A under 55, B over 55, calcium channel. Step 2, now combine both, A and C. Then step 3, you add D. And resistant hypertension, you can use an alpha blocker or a beta blocker. D is diuretic, B is beta blocker, C is calcium channel blocker, A is ACE or ARB. Diuretic is not recommended as an alternative to CCB at step 1 and 2 due to superior benefits of calcium channel blockers demonstrated through various clinical trials. So, if you want to use 2 drugs, they must be A and C. This is available now. Cilnidipine, telmisartan, amlodipine, telmisartan, amlodipine, ramipril. These combinations are very much available. So, blood pressure management in patients with diabetes. What will be the first drug that you use? You must always use the ACE inhibitors. CCBs are proven benefit monotherapy or as a combination with ACE inhibitors. Calcium channel blockers with ACI associated with significantly less incidence of new onset diabetes in comparison to beta blockers and diuretics. If you use beta blocker and diuretic in a diabetic patient, new onset diabetes will be precipitated. Better you use ACE inhibitor with a combination of CCB. Amlodipine, the third generation CCB. Nifedipine, nitrandipine, diltiazem, diltiazem, and then felodipine, isradipine. These are all older drugs. Amlodipine is better. Lecidipine, lernacidipine, nicardipine, nisoldipine. So many drugs are there. But out of them, the popular one is the amlodipine and now the cilnidipine. Okay, what is cilnidipine? A novel calcium channel blocker. Novel dihydropyrimidine DH type of calcium channel blocker with L and N type of channels. Both are blocked. Cilnidipine possesses the ability to inhibit the calcium influx, and then vascular smooth muscles are relaxed and neuronal cells are also, this calcium influx is reduced. Cilnidipine brings about cardioprotective effect, renoprotective effect, neuroprotective. Usually, my treatment for hypertension is a combination of cilnidipine with telmisartan because I have to use two drugs. The two brahmastras are, one is the cilnidipine, the other is the telmisartan, which is the ARB. Mode of action of cilnidipine, it acts on the both types of channels, and then it prevents vasoconstriction, dilates the blood vessel. On the heart, it is increases the cardiac contraction, and on the kidney, it is renoprotective. Cilnidipine, by blocking abnormal sympathetic activity, potentially reduces the risk of cardiovascular events also. Now, what is the summary? Monotherapy is contraindicated. Don't try to treat with one drug. Only 7% of hypertension are controlled by one drug. Now, the clinical reality is we require combination therapy. What combination? I have to use ACE inhibitor and calcium channel blocker. They have synergy in 93% are still uncontrolled. Another 7% are there who are controlled. Most of them are uncontrolled. Node A, ACE inhibitors, that is the type of drugs. Next type of drugs, calcium channel blockers, diuretics. So out of them, A plus C, not controlled, you add A plus C plus D. That is the logic now according to 2020 ISH Framingham ISH framework. That is the 2020 guidelines. You have A plus C plus D plus or minus D. Okay, nice algorithm. 2022 algorithm. This is the latest algorithm for stepwise initiation. First step, initiation. Under 55, start A. Over 55, start C. Now, you combine both and there's no control with one drug. Then dual therapy, A plus C. And if necessary, you add D if CCB is not tolerated. Nice guidelines 2022 algorithm, escalation to triple and resistant therapy, triple therapy, BP remains uncontrolled on dual therapy, A plus C plus D. A is ACE inhibitor, C calcium channel blocker, like amlodipine, and D is the diuretic, preferably not Lasix or any furosemide or that kind of drugs, thiazide like diuretic. But two drugs are there. One is the chlorothiazide, the other is the hydrochlorothiazide. Both can be used. Resistant hypertension, controlled despite optimal doses of uncontrolled hypertension, despite optimal doses of A, C, and D. Three drugs are used, uncontrolled. Out of the three, one is a diuretic, and that is not controlled, resistant hypertension. This we will take it up as a separate class, resistant hypertension alone. Confirm with ABPM, home blood pressure monitoring, check for non-compliance and secondary causes. Add low-dose spironolactone or alpha blocker or beta blocker. So in fact, for yesterday's patient, I not only gave him cilnidipine and also the telmisartan, I added him half tablet of spironolactone, 25 milligrams of aldactone, half of that is 12.5 to start with, so that he can be controlled. Don't forget to evaluate for obstructive sleep apnea. In this last 6 months in this community itself, I have unearthed 5 cases of obstructive sleep apnea causing hypertension. They come here with hypertension, we evaluate, they have obstructive sleep apnea. One fellow is there, I started him on this CPAP. Now today, what his blood pressure was 180, 190 by 100, 110. Today, 120 by 80, 130 by 80. Very well controlled with he's thankful, very thankful. Says, doctor, if I had not come to you, I would not have got diagnosed about this sleep apnea, which means my hypertension would not have been controlled. Now, spotlight on vascular protection, modern CCBs. What are the third generation? CCB, amlodipine, gradual in onset, Long duration, once a day is sufficient. Avoid reflex CNS activation. If you use, nifedipine or nitrandipine or the other earlier forms of uh, I mean, calcium channel blockers, reflex tachycardia was a problem. With amlodipine and cilnidipine, reflex tachycardia is minimal. But one problem with amlodipine is ankle edema. So many people whom you put them on amlodipine, they come after 2 weeks or your treatment is okay, but my legs are swollen. Never my legs were like this, and they are having water. What do you do? Immediately you prescribe that. No, you should not. That is not the treatment. The treatment is elevation of the limb, reassurance. Add ACE inhibitor. If ACE inhibitor is there, usually the edema is. This is a venodilatation, nothing. The edema is due to vasodilatation. Vasodilatation, venodilatation is causing the edema. At most, you can give some compression stockings. It will resolve. No need of giving diuretics for the sake of edema. So novel CCB, cilnidipine, unique mechanism on the L-type and the N-type calcium channels. Both are blocked, inhibits calcium influx in vascular smooth muscles and neuronal cells, actively blocks the abnormal sympathetic activity. Pleiotropic benefits, cardioprotective, renoprotective, and also it lacks the pedal edema profile of the standard calcium channel blockers. So always you can prefer cilnidipine, slightly expensive, you can do that. The 10 commandments of modern hypertension, or something like a take home. Screen every adult above 20 aggressively for blood pressure. This is called opportunity screening. You don't have to go into the community and start taking blood pressure for everyone. That is not feasible also. But fellows will come to you for one reason or other. Let us say somebody has come for urticaria and itching. I take the blood pressure. I will not only just treat urticaria and sand. That is called opportunity screening. You must screen everybody whom you come across as a healthcare provider to do opportunity screening. Treat the whole patient and not the number. The blood pressure is not here. Blood pressure is all over the body. Okay, not the number, but actively hunt for the co-thieves. Who are they? Diabetes, dyslipidemia, CKD, obesity, metabolic syndrome, myocardial heart damage already. These are the co-thieves. CKD, total lifestyle change. Not only treating the blood pressure, salt restriction, alcohol restriction, weight control, physical activity, controlling diabetes, controlling dyslipidemia. This is called total life. The approach is total lifestyle vascular approach and not a number approach. Do not stop at the arm cuff. Blood pressure is not a disease of the arm. It is a disease of the body. Evaluate for target organ damage. What are the most important things? Left ventricular hypertrophy, microalbuminuria, ankle brachial index must be done in all cases of hypertension. Utilize ABPM to identify the dippers and non-dippers and white coat variations. And here I have not listed on this slide. Don't forget to look for sleep apnea, history of sleep apnea. Ask the wife or husband whether there is snoring or midday drowsiness. If somebody is drowsy during working hours or when in the class, it means they are a case of obstructive sleep apnea. They must get this done. I've told many people, including doctors, but they have not followed. They have not done the sleep apnea test. If the sleep apnea test is done, definitely it will be positive. Daytime drowsiness and then, sort of malaise and also night snoring, hypertension are indicators of the obstructive sleep apnea syndrome. You must unearth that. So I told you half a dozen fellows, they identified in the small community of 600 people here. 6 people I have identified over the last 8 months. Recognize that monotherapy is dead. Initiate combination therapy A plus C, then if necessary D, logical. Leverage chronotherapy, nocturnal dosing to reduce overnight cardiovascular events. Most of the myocardial infarctions are major acute coronary events are in the early hours of the morning, between 4 a.m. to 8 a.m. If you target your coronatherapy, you can reduce the overnight cardiovascular events. Prioritize wide pulse pressure. Don't ignore wide pulse pressure. What is wide pulse pressure? Systolic 160, diastolic 60 or 70. Normally, SBP minus DBP should be 40. If somebody's pulse pressure is more than 40, it is wide pulse pressure. It is a clinical sign of arterial stiffness. What is the clinical sign of arterial stiffness? Wide pulse pressure. Means systolic is high, diastolic is normal or slightly low. Drive BP to the drive BP to specific high risk targets less than 130 by 80 as per the standard ADA, less than 120 as per the kidney guidelines. Insist on unrelenting compliance and follow up whether the compliance is there or not to bridge the gap between the actual blood pressure and the goal blood pressure that is achieved. One thing is to diagnose blood pressure and then diagnose TOD, diagnose the associated diseases, and also do LVH, MAU, ABI, and ABPM, sleep apnea test. The other thing is to keep the patient on the medication and see that he is compliant and the goal blood pressure is achieved. Today, even in the best treated countries like United States, you will be surprised to know the goal blood pressure is achieved in less than 15% of the patients of hypertension. Means what? If 100 patients of hypertension are diagnosed and put on treatment, only less than 15% are on the targeted goal blood pressure. If you don't achieve the goal blood pressure, the whole story of you studying medicine or studying hypertension is a waste. It is waste. I tell you, if you don't keep the goal blood pressure to the patient, you have done a world of harm to him or her, and the person Uparwala is ready to make a note. This lady doctor, this doctor has not taken the oath to keep the goal blood pressure in her patient or in his patient. So punish them. What we punish them with what? Give them hypertension and target organ damage. That is the best punishment God can give. Understand? Such is the importance of this disease. Now, what drugs? What are the various effects are this one, you see. Diuretic, ACE inhibitor, beta blocker, calcium channel blocker. So green, you see, which is green? Maximum greens you are seeing on the ACE inhibitors, beta blockers, and to some extent calcium channel blockers. Diuretics to some extent. So beta blockers mostly negative. So that is why what you have to do, choose the right drug for the right patient. Now, suppression of reflex sympathetic activity, overactivity, efficacy of ambulatory blood pressure control, positive effect on heart rate and autonomous nervous system, efficacy in blood pressure control and pulse rate, efficacy in rational and combination therapy, efficacy in the elderly and obesity, renoprotective, antiproteinuric, antioxidant, efficacy in arterial stiffness, isolated systolic hypertension, and on the renal function, efficacy on the metabolic syndrome, no ankle pedal edema, pleiotropic benefits of ACI, ERB, and cilnidipine. Anyway, this combination is murderous combination. Cilnidipine with telmisartan. It's a good combination. Direct renin inhibitors, other options for hypertension are future treatments. Direct Elucidation, neuroendopeptide NEP inhibitors like omeprazole or new aldosterone antagonists, eplerenone, aldosterone synthesis inhibitors, new centrally acting drugs like gonfacine, 10x is the brand name, cilnidipine extended release formulations, deruxtecan, like endothelin antagonists, novel combination algorithms are coming. These are the future options. Physician's bias in hypertension. What is physician's bias? This is called physician inertia. Somebody having 160 systolic blood pressure. No, 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 this is age. You will have 160 at that age. Very wrong physician idea. Nobody should have blood pressure more than 130, irrespective of the age. Hypertension is not a systolic hypertension is dubbed as an aging factor. To consider hypertension is only in the arm is the worst sin you can do. No concept of pulse pressure, not seeing the whole, seeing only a part of the problem. Worry about the side effects. So when you treat with any drug, certainly you have anticipate side effects. You don't have to worry, need to watch them and correct them. Okay, some control is achieved. No, 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 no. Earlier he was 200 by 110. Today it is 170 by 108. Okay, some control. No, I am not at all interested in that some control. You must bring it to the goal blood pressure, not insisting on compliance with the drugs and assessment. If the patient is not heeding, write in black and white. This patient I have advised sleep apnea test. I have advised ambulatory monitor. She or he has not done. The risk is left to her or him. Pressure from the patients. They keep on asking, how much, sir? How much, sir? How much, sir? How much is the blood pressure? The moment you tie the arm, the first question is they are on the number. I care least about the number. I care most about target organ damage and associated things and goal blood pressure. Concentrating on the pill and not concentrating on the ill. Pill is what? You give one tablet or two tablets. But the ill is more important. Total lifestyle is totally forgotten. Total lifestyle is totally forgotten lifestyle today. So you have to revive it. And total lifestyle must be taught to every student and must be educated to every hypertensive patient. Bridging the gulf of vascular protection. What is the bridge? High blood pressure is merely the loudest alarm of systemic cardiovascular collapse. Suppose there is a continuous alarm in your house. What do you think? Or in your work environment, like that, a continuous alarm for 5 minutes, some emergency going on. This is that. Blood pressure is a continuous alarm of something happening inside. Just like fever is an alarming sign of something happening inside. The gap between knowing the guidelines and actually achieving the guidelines is most important. This is the biggest gulf you have to bridge. I know everything, including Vedanta, but I never practice. What is the use? In theoretical knowledge in the brain cells, unless that is applied and then made into an anubhava or the experience. By shifting our paradigm from isolated metric of the blood pressure to control of the comprehensive structural protection, we do not just lower the numbers, we preserve the organs, we extend the timelines, fundamentally protect the patient's future. So this is the old bridge, and this is how the new bridge should look like. This is San Francisco Bridge, which I visited exactly 14 years back in the same month. Okay, now high blood pressure recorded is only a clinical marker of CV disease. Hypertension is a multi-organ disease, often asymptomatic, not to consider an isolation. Must look for the co-thieves. Today's goal blood pressure is not 130, 140, 90, it is 130, 80. Sure, it will be less tomorrow. I have written on the slide, now it is already less, 130 by 80. It matters to attain goal, matters more how it is attained. DM, CKD and IHD, the cutoff values are 10 millimeters less. Remember the rule of half, adequate control occurring only in 7% of the people who have blood pressure. With these take-home points, I'm going to close the talk on hypertension. If you have any questions, you can put it in the... Now, some more are there. Increasing systolic blood pressure, more important than diastolic blood pressure, often it is ignored. Wide pulse systolic blood pressure is dubbed as old person's disease. It is not so. Wide pulse pressure signifies arterial stiffness. Today's days of monotherapy have gone. Combination treatment is the rule. All hypertensions must be screened for CH risk factors and addressed. Target organ damage must be investigated and treated. LVH is the single most important predictor of mortality and morbidity. Ankle brachial index, microalbuminuria, ambulatory pulse wave, blood pressure monitoring, pulse wave velocity, sleep apnea test, identify high risk cases very early. Check and screen everyone above 20 for hypertension. Diagnose early, treat early, prevent the onslaught. Screen for associated CV risk factors. Evaluate target organ damage. Do not stop short at BP recording. Insist on compliance, follow up, and achieve goal BP. Consider ambulatory BP monitoring. Dippers, non-dippers. Waist circumference is a must. Use two drugs with complementary actions. Chronotherapy, nocturnal dosing. Put every hypertension on vascular protection. BP to BV. BP is blood pressure, BV is blood vessel. We are no more concentrating on BP, we are concentrating on the blood vessel. Where is the blood vessel? It is everywhere. So I am concentrating on all the organs. Patients have diabetes mellitus, CAD, CKD, and PAD with more comprehensive evaluation. Mandatory 10 commandments. Thus, this is the hypertension update, a paradigm shift from BP to BV and vascular protection. With this, we are stopping here. If you have any questions, all of you are able to open now.